Yes. Okay. So maybe we're going to start our ACNS YNS webinars today. So good morning, good afternoon, good evening, everyone from all over the world. It's my honor to start this ACNS YNS webinar today. So on behalf of the Educational Committee of the ACNS. So today our chair is Professor Florian Moser, who is the professor and chairman the Department of Neurosurgery, Neurological Institute of Cleveland Clinic, Abu Dhabi. So our expert speaker today would be Professor L'Oreal Jeshimasu, who will talk about the long-term results of hearing function after microneurosurgery for vestibular schwannomas. Our YNS speakers today are Dr. 𝒀𝑵𝑚𝒆 𝒂𝒂𝒂𝒂𝒏, who will be talking about microsurgical resection of complex 𝑨𝒂𝑚𝑈s encasing cerebral arteries, a cerebral vascular neurosurgeon approach to neuro-oncological pathologies. Our expert speaker today is Professor Brian, who will be talking about global neurosurgery and neurosurgery in a developing world, intraoperative intermittent clamping of external carotid artery for surgical removal of huge meningiomas. Along with us for the discussion, we have Professor Alexander Wojciech, who is the chief of the Neurosurgical Center Clinical Hospital Pioneer, president of Ukrainian Association of Neurosurgeons, and also along with us is Professor 𝑚𝒉𝒆 𝒂𝒌𝒆𝒓, who is the professor of Kabul University of Medical Science. So to moderate this session, we have Dr. Surgeon, me, Dr. Benton, and also Dr. Islam, and also Dr. Ashley. So may I hand over the floor to our chair, Professor Rosa, to introduce our first speaker.
Yeah, thank you very much for all you being here and to live observe and listen to a very important lecture. As we all want to improve outcome in vestibular schwannoma surgery, it is important and crucial to talk about hearing preservation and whether this is short-term or long-term. So we're all looking forward to your lecture. Professor Jeshimasu, who is currently lecturer at the Department of Neurosurgery, Tokyo Medical University, and fellow in the Department of Neurosurgery in La Boursière, Paris, France. So please, Professor Jeshimasu, go ahead.
Okay. Thank you, Professor. Now, can you see the slide?
No.
Oh, sorry. How is it?
Not yet.
Not yet.
Oh, not yet.
先生、下の緑の画面共有のボタンを押して。
はい。ちょっとなんか、あれですね、設定で問題がちょっと出ちゃってるんで。sorry, let me go later.
先生、2番目にしましょうか。
okay. すいません。
はい、大丈夫です。
はい。
So, Dr. Ben, Ichima Sensei want to become a second speaker.
Okay, then
Yeah.
maybe sure. So maybe Dr. 𝒀𝑵𝒻𝒆.
Yeah.
Are you available to present?
Yes.
Now. So thank you. So Professor Rosa, so shall we invite Dr. Martinez to start this presentation?
Absolutely. Dr. James Martinez Santos, please go ahead. Very important lecture. on the resection of, I guess, more insular gliomas, which frequently engulf the cerebral arteries. And we need certainly an update from the neurosurgeons about these treatment options. So please, Dr. Martinez, go ahead.
Thank you so much. I need to leave the webinar and then log in again so I can be able to share the screen. So give me 1 minute.
Okay, Dr. Martinez has joined us.
Dr. Martinez? Yes.
Do you guys see my screen?
Yes.
Yes.
Awesome.
Yes, we can hear you.
Perfect. Yeah, sorry about the technical difficulties. I was having to log in back on and to be able to share my screen. Thank you so much for the invitation. My name is Jaime Martinez, and I work at the Medical University of South Carolina in Charleston. It is my honor to be here talking today about the microsurgical resection of complex gliomas encasing cerebral arteries in my perspective as a cerebrovascular neurosurgeon. I have no disclosures for this talk, and this is the outline of my talk. I will briefly comment on what are complex gliomas, what is happening to glioma microsurgery, what is the microsurgical strategy that typically used for this complex gliomas, and I'll present 3 of our cases. So what is happening to the microsurgery of gliomas, in my opinion? The goal has always been the same of maximal safe resection, remove as much tumor as we can. And our goal as neurosurgeons to become better at our craft, being better microsurgeons. But the microsurgical skills have been underemphasized in literature, in all the publications we have, even in the journal covers. But the use of adjuvant therapy has been wrongly overemphasized. You often hear people saying, stay away from blood vessels, don't touch the blood vessels, this is a cancer, you will not cure this patient. But we all know that as the more tumor you remove, the better the patient does. You keep seeing journal and social media publications overemphasizing the use of radiation, even in benign posterior fossa tumors. And these are some of our journal covers emphasizing radiation, chemotherapy. And Dr. Fukushima, in his book, said it very well. We need to learn how to operate. We need to learn how to be better surgeons. I don't see much discussion on the technique, on how to dissect small blood vessels from the tumor, how to deal with the different tumor invasions to the blood vessels and things like that. So this is the purpose of our talk today. We keep seeing this, my mentor, Dr. Bashkaya, learning gamma knife neurosurgery and sleep therapy and all that stuff. So in my opinion, what are the complex gliomas? So I think complex gliomas are those that encase major cerebral arteries. Those are located in perforated rich areas. Those are deeply located. The surgical corridor is very narrow, and gliomas in the insular diencephalon membrane stem. Whenever we talk about complex gliomas, we need to always go back to Jan-Sergej's publications and textbook and look at the limbic and paralimbic tumors. These tumors that you can see in areas of light and dark blue color are the archicortex and para-archicortex. Those tumors in this location, like cingulate gyrus, the insula, the parahippocampal gyrus, and the hippocampus, they are particular because they have dual arterial supply from the leptomeningeals and perforators, and they have specific growth patterns to them that you need to account for when you're removing them, so you can extend your approaches accordingly. And I'll show you in some of the videos. These are the basic principles that we take for complex glioma surgery. It starts with a skin incision and then progress to the micro dissection. Has to be a wide arachnoid dissection, free up the brain, have always access to CSF for brain relaxation. And then the basic tumor resection principles are the same: devascularize, debulk, and dissect. I think it's also very important to gain some experience identifying normal surrounding white matter, how to notice for subtle changes in color when you're doing the resection, finding the fissures, the sulci, the arteries in the sulci, the gray matter next to the sulci. And I think a very important point is learning how to identify basal ganglia, which is particular. And I'll show you in the video how it looks. But I think, in my opinion, knowing that saves you the need for needing 5-ALA and other adjuncts to surgery. Let's talk about a little bit on the glioma arterial involvement. This is something we're working on in the lab right now. And we came up with 5 levels of arterial involvement in gliomas. The glioma can be in proximity to the blood vessel, but not involving the adventitia. It can be contiguous to the adventitia, stuck to it. It can be infiltrating the adventitia, and that has several degrees. Can be partial encasement or can be a 360-degree encasement. And then after that, you can have some vessel stenosis and even vessel occlusion and stroke. The dissection technique for this tumor progress from at the beginning a little bit of a subpial resection, staying away from the pia if the tumor is just next to the blood vessel. Then at the beginning, you start with traction, counter traction, to slowly peel away the tumor from the blood vessel and to identify, which is a very important point, identify all the small side branches that go to the tumor. This is important because you want to find those and bipolar coagulate them and divide them. That also devascularizes the tumor, makes it less bloody, and makes surgery easier. And then we found that using the sonopet is extremely useful when you're working next to blood vessels. You can do very low settings. If it's like a small vessel, like a leptomeningeal, you can do 5 on the sonopet. And if you're working next to bigger vessels, you can go a little bit higher with the sonopet. And then using as much of sharp dissection as you can do. Also kind of changing between sharp and blunt micro dissection. Don't be dogmatic. I always do this. I just kind of try different things, take your time dissecting, and try to do a good job. So the first case I have is a patient, 64-year-old male with headaches, dizziness, lightheadedness, and memory problems. And he has a multifocal tumor. There's a tumor here on the surface, and then also a deep anterior cingulate tumor. that is extending into the ventricle, extending into the corpus callosum, people call it butterfly, glioma, and then getting into the ventricle. So for this tumor, our strategy was to go on the left-sided frontal craniotomy, remove this tumor first, go down, find the deep tumor, and then find our anatomic landmarks. We always have anatomic landmarks for these surgeries. And in this case, where the interhemispheric fissure, then the callosal marginal and pericallosal arteries, then the ventricles, and the corpus callosum. So this is just quickly showing resection of the superficial lesion. The superficial lesion was removed, and then you keep coming down through the white matter. And the initial goal is to find the ipsilateral blood vessels and then find go work under the fox here, just for orientation. This is anterior and this is posterior. And this is like a left-sided craniotomy. This is the fox. And then you work under the fox and find the contralateral ACA vessels. Then you work on the ipsilateral callosal marginal. So we had the callosal marginal around here, this area here, and then the pericallosal that we are finding here. And then you know that from here to here is safe. Then you debulk aggressively as much tumor as you can with the sonoped, with scissors. This is just a callosal marginal branches. And then you can work next to the blood vessels, dissect tumor from it, traction, contratraction, then finding the small side branches here, bipolar coagulate them and divide them. You can see like we work next to the blood vessel and we remove tumor off the blood vessel, and that's okay to do. You take your time and you do it. Find the deep feeders to the tumor, bipolar coagulate them, divide them, then dissect the tumor off the pericallosal branches, as you can see here, using sharp dissection. This is the left-sided, this is the right-sided one, just working over the corpus callosum. And then using the sonoped at low settings, right over the blood vessel, you see it's safe. And then you can also preserve the tiny branches, as you can see here, and take tumor off them, go and remove tumor from the corpus callosum that is deep to that, working between the blood vessels until you find the ventricle. And that will be the limit of your resection. So this is post-op imaging showing complete resection of a tumor. And the patient did well, was discharged home and had no problems. The second case, a 54-year-old gentleman with a similar tumor, a little bit more posterior, cingulate gyrus tumor. And in this case, our surgical strategy was to do an interhemispheric approach, go this way, find a tumor, and then work between the callosal marginal and the pericallosal branches, remove tumor laterally, and then go deep, find the corpus callosum, then enter the ipsilateral ventricle and also the contralateral ventricle. So we had to identify those ventricles so we know that we had achieved a good resection. So again, for orientation, this is a left-sided craniotomy. This is the front and this is the back. And this is a fox here. We turn the head. Mostly for all cases, we do interhemispheric. We turn the head and depending on where we want to go, if it's very lateral, then we can do contralateral, like cross-court approach. But mostly we do ipsilateral side down for some gravity retraction. We don't use fixed retractions. And go down to the tumor, then this is all tumor, and then these are the arterialized veins, callosal marginal artery. Then you bipolar coagulate the side branches, and here we're coagulating all the arterialized veins. It's also important. Identifying normal vessels from the tumor vessels. And then you work posteriorly, find the posterior pole of a tumor. So you can see here normal white matter, then aggressive debulking with the sonopet, then working around the callosal marginal, finding the lateral aspect of the tumor here, and then doing the same, finding normal anatomy here, and going from normal to abnormal. So basic principles. Doing the side branches here again. And then removing more tumor deeply until we enter the contralateral. You can see contralateral here, contralateral ventricle, and then ipsilateral ventricle here. And then this is just between the septum here, between the two ventricles. We remove the anterior part of the corpus callosum that had tumor in it. And then that way you can remove most of the butterfly gliomas in a safe way. At the end, I want to mention too that we put some sodium nitroprusside or papaverine over the blood vessels to prevent some vasospasm. It's hemostasis and all that. That's post-op imaging showing complete resection. And this patient also did well. And then for the last case, I have a 59-year-old gentleman with some aphasia and headache and facial droop, and has this very sizable insular glioblastoma. And he was said that this tumor is inoperable at an outside hospital. But with microsurgery and the current technology we have, I think for most of these cases, we should offer surgery and take our time, do our dissection. And the surgical strategy for this is even simpler than the other ones. It's just finding the fissure, doing a wide Sylvian fissure split, finding the circular sulcus or the limiting sulcus of the insula, then finding all the blood vessels from the MCA branches that are usually on the limiting sulcus because they get pushed by this tumor. And then doing your tumor debulking, and then knowing how to identify the striatum, the basal ganglia, how it looks, how it bleeds, how it feels to the sucker. It's just a picture of the central core of the brain after removing that part of the frontal temporal lobe. And that's the insula here. You find the anterior, posterior, and superior and inferior limiting sulcus of the insula. And then you go deep until you find the basal ganglia that I'll show you in the video. So again, left insular glioblastoma. And you can see here, this is the left-sided surgery. And this is frontal, and this is temporal. These are the veins. So you can see that after a very short Sylvian fissure split, you can see the tumor here that is pushing the opercula and opening the opercula. Take your time finding the normal veins, bipolar coagulating in the tumor veins, then doing your Sylvian fissure dissection. And again, the goal is to find the circular sulcus or limiting sulcus of the insula. So you can see here going over the tumor and then finding some of the MCA vessels. After you have some anatomy, then you go in and debulk. You shouldn't go and debulk before you have an idea of where the anatomy is. Then you go in and then debulk with a sonopet. Again, do more dissection, identify the M1 there, deep, and the inferior limiting sulcus with some more tumor and the M2s there. And bipolar coagulating in the side branches, the same principles that we used initially. Devascularize the tumor, and then more dissection. You can see here on the superior aspect of the tumor, dissecting and removing. Then this more dissection on one of the M2s branches of the MCA. You can see that you use traction, contraction, and sharp dissection. Keep using the sonopet. see how you can use the sonopet right over the blood vessels without much problem, finding normal white matter underneath. And then an important aspect is these tumors tend to grow down into the temporal lobe. So if you find the inferior limiting sulcus and you follow it, so you can see here, M1 and the M2s, find the inferior limiting sulcus here, this temporal side, frontal side. You follow the white matter there, it will take you down to the temporal horn. So you can see here, the temporal horn of the lateral ventricle. And that's a good landmark too to know, and remove as much tumor as you can down that way. And post-op imaging showing good resection. Gross total resection is a little bit of a hematoma, but nothing major. Patient did well. He was also discharged post-op day 7. So the goal remains trying to achieve a maximal safe resection. Have a good strategy. Expose the blood vessels, find normal, go from normal to abnormal, and then learn your dissection technique of traction, contratraction, using as much as sharp dissection that you can use, and then going from there. Knowing the anatomy is key, and knowing how to identify the basal ganglia, how it bleeds, has like a little punctate bleeding to it, that feels a little different on your sucker and your sonopet. And that's all I have. Thank you so much. And I don't know if you want to do questions now or later.
Yes, thank you so much for your lectures. So before I invite a question, I also want to say Professor Louis Baba has already joined us today. Hello, Professor. Yeah, please unmute yourself. Professor Louis Baba.
Good morning.
Yeah, is a well-famous neurosurgeon who is the professor and chairman of neurosurgery at the Federal University of Paraná in Brazil, and also the chairman of educational committee of WFNS. So he's also one of our co-chair today. And just now we have finished the first YNS lecture with Dr. Martini. So shall I invite Professor Rosa and also Professor Barbara to comment, to invite our discussion, and also can make comments on his lecture.
Yeah, thank you very much for this first lecture. I don't know who else from the moderators is besides Dr. Ben is with us, but that opens up, of course, a lot of questions for this nice presentation of very complex gliomas. So I would have a question up front to start with to Dr. Martinez. So seeing you going into the Sylvian, into the left side Sylvian fissure, resecting these insular gliomas, are you using electrophysiology? Do you stimulate subcortical? Because I think that is an important tool, and I agree, more than fluorescence guided surgery, to stimulate, to know how close you really get to the motor pathways. You want to comment on that?
Yes, that's a good question. We don't typically use awake surgeries for this, but we do motor mapping, we do sleep motor and some of the sensory evoked potentials, and we do some stimulation. Sometimes it's not as reliable, so we rely more on the anatomy, to be honest with you, especially in glioblastomas and especially in patients with already deficits. So yeah, that's a good question on stimulation. Yes, we use always neurophysiologic monitoring with motor and sensory evoked potentials, but not.
I agree, awake. Right? We don't want to chase the fluorescence, right, in these tumors, because the limitation is not necessarily the least tumor margins or the enhancement on fluorescein. It's really functionality or what you visibly see under the microscope. And
Right.
in awake surgery, in somebody who's completely aphasic from a left-sided insular glioma doesn't make sense either. So it is basically electrophysiology in those cases, right? Okay. Any more questions from the other moderators and discussants?
Okay.
Say something.
Professor Wojciech, yes.
Yes,
Over.
thank you. Thank you, Professor Dr. Martinez. Thank you very much for great presentation. Great, really. First of all, great idea, great technique, and really great presentation. Thank you very much.
Thank you so much.
Really, recently, the glioma surgery became a field for experienced microsurgeons, where we can apply our skills. So microvascular skull-based neurosurgeon can apply their skill on surgery and to improve much more the result of this surgery. And you really showed in your video with your excellent technique of dissection of the vessels. So really, I enjoyed it very much. But the surgery is more complex, and not only dissection can solve all the problem of the surgery. So of course, it's first of all, it's intraoperative neuromonitoring. It's also, it's use of ultrasound intraoperatively, neural navigation, which cannot be applied after one tumor was relaxed. But you was mostly focused on magistral vessels. But for me, it's more complex questions. Is dealing with the perforators.
Mm-hmm.
But in my practice, when I do insular glioma and I meet long perforators, I visualize them. For me, it's I stop at this point. I do not try to dissect them because usually they are too fragile, they are too tender, and I usually stop. What is your option, and what do you do with this long? I don't speak about the short. Short you can cut; it's not a problem.
Yeah.
It's go to the surface, but long, which go to the internal capsule.
Yeah, it's a great question as well. We found that using the sonopet very close to those long perforators that usually come from M2, the M1 perforators we leave alone. You know, and usually this gliomas, the best ones are the ones that push the perforators medially, right? If they are pushed, if you see the vascular imaging and the perforators are kind of lateral within the tumor, that's not a good tumor, you know. But when we find the perforators like in the bulk of the tumor, not at the end, then we try to dissect slowly with sonopet at 5. It's very, very low setting, so it won't do anything to the perforators.
Mm-hmm.
And you can gently kind of work next to it and remove some tumor. But you always, it's hard to say, but you always need to see how the tumor is reacting, you know. If the tumor is coming, you keep going, right? If the tumor is not, if it's not coming and it's very hard and the setting is not working, then you stop. And you leave that little bit of tumor. So it's like a little bit of an intra-op assessment, but you can try with a sonopet at low settings and see if it comes.
Okay, thank you. So it means experience of surgeons is very important, yes, and very individualized technique from case to case. Yeah, thank you very much.
Yeah,
thank you.
exactly.
Thank you.
May I say something here?
Yes.
Good
Yes.
morning. Thank you very much, Professor Cato. Thank you, our friends, for opportunity to be here. Do you know what I saw in your case? First, today the glioma surgery, there is a battle. Physiology, anatomy. Some schools say that it's anatomical surgery. Another school say that it's physiological surgery. And you show that very beautiful technique. I think you train a lot in the lab. No? You do microsurgery for the glioma surgery. It's very, very important to use the anatomical base and the physiological base. This way you do the best treatment and the best way to remove this tumor. The low-grade glioma, for me, is the most difficult surgery. You see, we talk about complex scalp-based tumors, but the glioma tumor is the most difficult one because we need to know the anatomy, we need to know the physiology, we need to understand that sometimes at the end, it's difficult to say that it's tumor or it's not tumor. The fluorescein, the 5LA is not working, not depicting in low grade the same that you have in high grade. And the technique that you show is perfect. We would like to congratulate this wonderful video and treat the brain the way that the brain needs to be treated. With careful, microsurgical technique. And let me ask you something. Where did you train? Where did you learn this technique? Because your background in microsurgery is very, very good. Sorry to ask you because I came late.
No, I learned all I know from Dr. 𝒂𝒑𝒆𝒂𝒂𝒏.
Excellent.
𝒂𝒂𝒂𝒏.
Excellent.
I did my fellowship with him.
Okay, excellent. Yeah. Congratulations. Very nice.
Thank you.
Professor Farid, you have some comments? Professor Pritchard, you have some comments? Yeah.
Hello. Thank you very much. Konnichiwa. Greeting. Thank you very much, Professor Martinez Santos. It was great presentation, but good education message, and also it was best learning outcome as well. Thank you very much. It was great, especially for young neurosurgeons. It was good. And just I like to know about you mentioned about multiple glioma. Do you do in the same operation reject all this multiple gliomas or not? And what's your advice for endovascular embolization before operation? Do you advise or not? Thank you.
Thank you. Thank you. So if it's multiple gliomas, and I actually saw a patient in clinic last week with a thalamic glioma, and that patient had also another abnormal flare signal on the cortex. So when you have those kind of things, then that helps you with your approach, decide on how to approach these tumors. So you can probably do the superficial one and then go deep and take the deep one. If it's like a multifocal GBM and the patient is progressing quickly, then you have to assess the role of surgery and see if it's actually indicated. Usually is, because we know that the more tumor we remove, the better the patients do. But you need to keep in mind that for that to work, usually the number that we're looking for is at least 80%, right? So if you think that you cannot remove 80% of the tumor, then you have to question your indication. But yeah, if it's multiple glioma, I'll try to tailor my approach based on the superficial and all, like the 2 points, technique that Dr. Spetzler described, trying to reach to deep areas and going from there. But it's very different between patients. And embolization, for the question about embolization, I learned from Dr. 𝒂𝒂𝒂𝒏 to not embolize much of this. I never embolized glioma. And for meningiomas, you don't really need to most of the times, because you do an extradural approach and then take all the blood supply that way. And I have seen, I trained in residency in a very endovascular heavy program. So they would embolize everything, and we would see some problems from that too, especially for school-based tumors.
Thank you. Shakur.
If I may ask one question, Ben?
Yes, yes, please go ahead.
Okay, Dr. 𝑣𝑚𝒆, first of all, thank you very much for this very wonderful presentation, and it was absolutely fantastic. Just one question, that you showed that even on blood vessels, 𝑞𝒂 was safer. Up to what limit it is safe? Because I have seen catastrophes with 𝑞𝒂-induced major vessel injuries. So till what limit of 𝑞𝒂, what is strength it is safe?
It's a very good question, and you need to try it out beforehand. For instance, after I finished my fellowship, when I tried the 𝒂𝒂 at my place, the setting was a little different because I had the not the 𝒂𝒂, I had the 𝒀𝑵. So I used the 𝒀𝑵 in Madison, Wisconsin, and then I used the 𝒀𝑵 in South Carolina, and we had like a newer 𝒀𝑵 in South Carolina, so it was like a little different, but you tweak it up, and I would say safely to do, depending on the size of the blood vessel. If it's M2s or M1, you can do up to 10 or 15 even safely. If it's a perforator, then I wouldn't go more than 5 on the settings. You know, we usually keep the irrigation at 9-ish, and then the settings for tumors, like for this gliomas, I start at 20. So 20, 20, 9 on the settings. And then when I see an important small blood vessel, I move it down. So I'll say 5 for perforators and small vessels, and then for the big ones, up to 15. I wouldn't do more than 15 near big blood vessels.
Okay, thank you. One more question, if you permit. I came across a very interesting article which was published in Neurology India from one of the biggest centers, which is 𝑣𝒪𝒺, and they have analyzed the tissue samples which were histopathological analysis of tissue samples which were compared by conventional biopsy and 𝒂𝒂, and they had found that it was difficult to grade the glial tumors when the 𝒂𝒂 samples were analyzed, because of the it was difficult to distinguish brain metastasis and brain invasion and necrosis in the 𝒂𝒂 samples compared to conventional pathology. So do you make a point to send both the samples, or you only send the conventional biopsy for histopathology?
Yeah. We don't send any of the ultrasonic aspirator sampling. So we find the tumor, we cut it with scissors, and then take a lot of sampling. We have all been to tumor board, and they always say, "Oh, not enough sampling," but you try to take your time and take bites of the tumor that way. And then when you're happy with the amount of tumor that you have for histopathology, then you debulk, and in that phase is when you use the 𝒂𝒂 after you had enough sampling. We don't typically filter it out from the 𝒂𝒂. We just trash it.
Thank you very much.
So if there is no further questions, then shall I invite Professor Rosa to go back to our first speaker?
Let's give it a second shot for Professor Ichimasu. Very important skull-based lecture about the long-term results of hearing function for vestibular schwannoma. We all agree to attempt hearing preservation. So please give us some insights how you're going to achieve that. Thank you very much.
Thank you, Professor. Now, can I show the slide?
Yes.
Yes? Okay, okay. I'm sorry that I have some problem with heading. Finally, I got a connection. I'm so relieved. This is Dr. Ichimasu from Tokyo Medical University Hospital. I've been training of scalp surgery for over 10 years, and now I'm going to be a research fellow in 𝑣𝒆𝒂𝒂𝒔 Hospital in France since this month. In our institute, Tokyo Medical University Hospital, we have about 150 operations for scalp-based tumors, including 120 cases of 𝑣𝒆 𝒀𝑵𝑚 a year. This is my small publication about genetic surgery from my personal experiences. If you are interested in, you can see the YouTube video via the QR link. This time, I'm so glad to have such a wonderful opportunity to talk about my experience. I'm appreciative to Professor Kato Yoko. Thank you very much. So today, I will talk about the hearing function after vestibular schwannoma surgery. For this topic, I also made a publication. This is PDF link. Ahead of the story, just imagine when we talk about facial nerve function after surgery. If the facial nerve function has been preserved after surgery, we can expect its function will maintain permanently, like forever. In contrast, hearing function is not like that. In fact, hearing function will gradually deteriorate. It will be down in long-term period after surgery. This phenomenon, post-operative hearing deterioration, actually has been reported previously. This report is written by Kyushu University in 2013. They reviewed hearing function with over 5 years follow-up period in 24 patients who have useful hearing function after surgery. In this report, useful hearing function was preserved in 86% 5 years after surgery. Interestingly, this Kaplan-Meier curve shows that hearing function is going down after 5-year follow-up. It means at the time of 7-year follow-up, hearing preservation rate is 72%. This is lower number than it of 5-year follow-up. It means this phenomenon could be observed in very, very long-term period. They tried to find key factors for this long-term post-operative hearing deterioration, but the number of patients was limited. They couldn't find it. As this report from Kyushu University, previous reports were not sufficient due to the low number of patients or due to the short follow-up period. So this was our motivation to start this project. In our report, we retrospectively reviewed hearing function with over 5 years follow-up period in 91 patients of vestibular schwannoma with useful hearing function after surgery. And the purpose of this study was to report the characteristics of this phenomenon and try to find the key factors to decide the hearing function prognosis in long-term period after surgery. The subject patients meet up the following 2 conditions. First, patients have been confirmed the preservation of useful hearing function in the first auditory exam after surgery. Basically, the postoperative first examination was done within 2 months after surgery. Second point, patients undergone follow-up auditory exams at our outpatient clinic within the target period between December 2015 to December 2017. After excluding the patients with reoperation NF2 and regrowth, this study includes 91 patients with preserved useful hearing function after surgery. The patient background age was 39.5 years, tumor size at 18.9 millimeter, resection rate was 97.7%, and follow-up period was 63 months in average. For these patients, we reviewed hearing function through the various auditory tests. These auditory tests were performed at each point: PTA, pure tone average, SDS, speech discrimination score, and DPOAE, distortion product autoacoustic emissions, were checked at all points. ABR, auditory brainstem responses, was done at the point before surgery and follow-up point. The hearing function for each patient were evaluated by PTA and SDS using AO-HNS classification. This figure is showing hearing class from the left to right, before surgery, immediately after surgery, and follow-up, and up to down, class A to class D. In this study, the useful hearing function is defined with class A or B. So this yellow line shows the border between useful hearing function and not useful hearing function. And this green circle shows that the 91 patients have hearing function of class A or class B immediately after surgery. This is one of the inclusion criteria in this study. So this green circle equals subject patients. This group includes 64 patients for class A and 27 patients for class B just after the surgery. But you can see the distribution of patients is changed at the follow-up. You can find the differences between the patients' distribution. At the follow-up, the number of patients with class A is 22 patients. The patient's number is decreased. And for class B, increased to 57. And you can see that some patients lost their useful hearing function at the follow-up point, like their hearing function got worse to class C or class D, despite postoperative useful hearing function. Although everybody had useful hearing function just after surgery, some patients lost the useful hearing function in the follow-up period. This is that phenomenon, a postoperative hearing deterioration phenomenon. It certainly exists. And the patients were divided into the useful hearing maintenance group and the useful hearing non-maintenance group. And useful hearing maintenance group was 87%. According to these data, statistics analysis was performed using Kaplan-Meier curve. This curve shows that the preservation rate of useful hearing function was 94% at 5-year follow-up, and the hearing function will go down later than 5-year follow-up, 5 years after surgery. It's like 75% at 8-year follow-up and 65% at 10-year follow-up. Hearing function is gradually getting worse in very, very long-term period after surgery. Although there is a slight decreasing between 8-year and 10-year follow-up, but if the useful hearing function maintain until 9 or 10 years after surgery, this curve looks hearing function will get stable 9 or 10 years after surgery. So what is different between useful hearing maintenance and non-maintenance group? What is different? To answer this question, patient background and auditory tests were statistically analyzed. This is a result of statistical analysis for useful hearing maintenance group and non-maintenance group. The patient background has no significant difference between two groups. And auditory test, ABR and DPOAE revealed obvious differences. For ABR, we analyzed the improvement, which is more than 0.2 millisecond shortage of interpeak between preoperative point and follow-up point. And for DPOAE, we evaluated strengths of responses and saw the DPOA deterioration after surgery. In the useful hearing maintenance group, this is better hearing function group, we could find the better data from ABR and DPOA. It sounds like it goes without saying. Yeah, it sounds, of course, this. Yeah, because good hearing group has good result of hearing test. But this data is very important for me because from this data, we could find the reason of hearing deterioration after surgery. We are neurosurgeons, so we don't know about the auditory tests in detail, but this is general information about ABR and DPOA. Each auditory test tells the function of different locations. ABR reflects retrocochlear auditory pathway, which is auditory path after cochlear. This pathway equals cochlear nerve and brainstem, and so on. On the other hand, DPOA reflects inner ear function, cochlear. So from these data, we could find that the loss of useful hearing function is caused by inner ear and retrocochlear dysfunction. Let me go back to the slide about hearing class. And let's focus the blue circle, 64 patients, the group of class A just after surgery. This group was the most majority at this point, just after the operation. But the most majority group will be the patient for class B at the follow-up point. This is a typical case. 32-year-old female presented right vestibular schwannoma with a cisternal diameter of 14 millimeter. This patient has a hearing function of class A before surgery. Let me show the operative video. The region is right side. The resection was performed with lateral suboccipital retrosegment approach. After dissecting the arachnoid between the tumor and lower cranial nerves, REZ of facial nerve was found and electric probe was put for continuous monitoring. Now the cisternal tumor is being debulked. After then, intracanalicular portion is removed. And now you can see the bundle. This is cochlear nerve. And then nerve is isolated from the tumor. And then this is the brainstem and the facial nerve. Around the entrance of internal auditory canal, there's some adhesion between the tumor and facial nerve. And yeah, facial nerve was spreading by the electric probe, we could see. So the resection was stopped with 97% of resection rate. In this patient, useful hearing function was preserved with class A immediately after surgery. After 5.3 years of follow-up, there was no recurrence of the tumor on the image, we could see ABR had improved from 45 milliseconds to 3.9 milliseconds. But the hearing function goes down to class B. This case tells actual hearing deterioration despite of ABR improvement. At the same time, we can find that the useful hearing function was preserved with class B in this case. In this patient, hearing function was deteriorated, but within the useful hearing function. Now we must have the deeper consideration at this case. As we said, ABR reflects retrocochlear conditions. If the tumor exists in CP angle, the tumor compression causes retrocochlear disturbance, retrocochlear dysfunction. Basically, this retrocochlear disturbance is reversible, can be returned, because this disturbance is caused by tumor compression. So yeah, in the patient like this, if the tumor is removed enough to release the compression of tumor, ABR should be improved. And these findings should be maintained if the tumor has no regrowth. Now you can find these findings of ABR looks key factor to preserve the useful hearing function. Again, let me go back. As a next step, the patient were divided into hearing class maintenance group and non-maintenance group. These groups has no significant differences in the patient background. Comparing the hearing class maintenance group and non-maintenance group, significant differences was observed on only DPOA here. It means postoperative hearing deterioration is caused by inner ear dysfunction, cochlear. And through this analysis, finally, we found the key factor for the useful hearing preservation. As we said, the loss of useful hearing function is caused by inner ear and retrocochlear dysfunction. According to our data, if we preserve the useful hearing function after surgery, many patients will experience postoperative hearing deterioration in long-term period. And if the postoperative dysfunction remained only for inner ear, the patient could preserve their useful hearing function. Of course, also for most of these patients, hearing loss after surgery will come, but the hearing loss is not so severe within the useful hearing function. This is the most majority cause of patients who got operation for vestibular schwannoma and whose hearing function was preserved after surgery. On the other hand, if the postoperative dysfunction goes for inner ear and retrocochlear pathway, the hearing function will go down to not useful hearing function. We had much discussion about what happens in the retrocochlear auditory pathway, but we couldn't say anything about the mechanism because this phenomenon occurs very, very long term. If this phenomenon is caused by vessel problem, it should be just after the surgery. Yeah. So yeah, this mechanism is not clear. In this study, the preserved hearing function after surgery was investigated with over 5-year follow-up period. After the statistic analysis, useful hearing preservation rate was 94% at 5 years follow-up. This actually this data is superior against the data of radiosurgery. The patient who lost their useful hearing function begin to appear 2 or 3 years after surgery. So we think that follow-up period should be more than 3 years after surgery. And not only MRI, but also auditory tests should be followed for the patient. And the hearing deterioration will stop about 8 years or 9 years later from surgery. If the useful hearing function is preserved 10 years later, we can relieve, finally, because hearing function must be safe. Of all 91 patients, useful hearing function was preserved in 97 patients. But in fact, many patients experience hearing deterioration within the useful hearing function, like class A, just after the operation, and class B, follow-up period. And this slight deterioration is caused from inner ear dysfunction. Many patients will have hearing loss due to inner ear dysfunction. And some patients will have additionally retrocochlear dysfunction and lost their useful hearing function. Anyway, this postoperative hearing deterioration is very strange phenomenon and very interesting. The mechanism is still not clear, but these red notices kind of take-home message. Thank you very much.
Yeah, thank you very much. This is very important, detailed analysis. I learned a lot. Unfortunately, as you know, it opens up more questions than answers, right? Because we, as you pointed out, we don't know why the inner ear dysfunction deteriorates so many years after surgery. But most important, I would like to ask you, so what are we offering those patients? Do they benefit from hearing aid? Do they benefit even from a cochlear implant, right? Because you preserve the nerve anatomically, so they should be able to improve. When they lose serviceable hearing, they go down from class B, maybe even to class C and D. For non-meaningful hearing, would you think they would benefit from cochlear implant or hearing aids, other hearing aids?
Thank you for the question. Yeah, this is a very good point. But yeah, we sometimes think about the cochlear implant for this patient, this patient. But if the patient have the problem on the retrocochlear pathway, yeah, cochlear implant will won't work, we think. Yeah, and if we put the cochlear implant for the only the patient who have only inner ear dysfunction, that is yeah, it will work, of course, but the patient hearing function is not so bad. I mean, yeah, the patient who have the problem on the inner ear dysfunction is yeah, not so severe. So yeah, they don't need it.
Yeah, that's a very good point. And then the second question, you mentioned that, you know, in some key cases, which is totally justified, as you showed in your data, you leave 2 or 3% of tumor, very like a small carpet over the nerve. And then do you think that even though this remnant might not grow over the years, it still influenced the deterioration of the retrocochlear hearing deterioration? Like as a steel phenomenon, like taking away blood, supply to the cochlear nerve? I mean, I'm just asking.
Yeah, very good point as well. And yeah, there are so many hypotheses about this phenomenon. And some neurosurgeons say that this phenomenon is caused from micro regrowth, which means we can't see on the image MRI. Yeah, but there is a, yeah, they emphasize there is a regrowth, but yeah.
But still, you have excellent data, right? I mean, if you have after 10 years still 60% with hearing function and no visible regrowth, that's excellent. I mean, that's the best you can offer your patient. I wouldn't change the philosophy then. What do you think, Louis?
I was thinking here about the radio surgery data. We say that when you do radio surgery, that it works for acoustic neuroma. With the time, you lose the hearing. And one thing that if you say, oh, you need to do surgery that you preserve the hearing, it will be forever. Now you see that's not the same way. But one important issue, you see, there are another cause that the patient can lose the hearing during his life. If they age, other morbidities, or is the aging process. If the guy you're losing the hearing. This is a very important issue that you should analyze more than the acoustic neuroma by itself. When you see the patient that was treated for radio surgery, if you see the MRI, the cochlea, the labyrinth are different, are bright, are like inflamed, things like that. It's completely different. But in surgery, you see that the anatomy is preserved, the nerve is preserved, but there is more issues. This paper will be used by the people from radio surgery, see? To say that the nerves, the microsurgery is not, the hearing preservation is not forever. I think it will be a very important issue. Other thing that is very important that is changing a lot in the last years. What is useful hearing? Maybe preserve 10%, 20% of the hearing. Can save life. Many surgeons, especially Dr. Lomef, they show one video that the guy in the train station and came the train. This very low percentage of hearing preservation can save the life. Maybe not useful for conversation, but is useful to save the life. But I want to ask you something. I ask this for everyone. Everyone has his theory. I know that people using nimodipine, is a vascular. What's the trick, real trick, to preserve the hearing? Preserve the hearing is a microsurgery in technique, or the way when you preserve the facial, the cochlea will be in the same packet. What's the trick? The real trick. I want to learn.
Yeah, thank you, Professor. Yeah, we tried to do some study for the preservation for hearing function preservation. If we know the if we can preserve the hearing function before surgery, it's a very useful. But yeah, actually, it depends on the findings. Intraoperative findings of the cochlear nerve is a very important. Yeah, the case I showed, the patient has a bundle of cochlear nerve. That's finding is very important. Yeah, and in some patients, you know, the cochlear nerve is like melting. Yeah, it's a very difficult to preserve. Yeah, so yeah, in fact, the how to preserve the hearing function is very important, but actually it depends on the patient's condition. Yeah. Thank you very much. Yeah.
Let me ask you, your intraoperative neurophysiology monitoring may be an issue in this? When you put the electrode in the posterior fossa directly in the brainstem. For facial nerve, I know that it's perfect. For hearing also can be an issue? The way that you do the intraoperative monitoring?
We used usually CNAP for the auditory function. Intraoperatively, we perform the intraoperative monitoring for the auditory function. But yeah, it's very tricky to preserve the hearing function still using the CNAP. Yeah, it depends on the findings of the cochlear nerve.
No, I want to just comment. I agree to all what has been said. So we're using near field acoustic evoked potentials, a little bit more robust to follow, but sometimes it's really looking at the tumor. It can be very large acoustic T4, whatever. The acoustics are very stable, can be very small one. You just put some irrigation or blood on it and the acoustic evoked potentials go down significantly. It's very hard to predict. I think a stable acoustic evoked potential prior surgery is a very good predictor. And the second thing which I found in terms of techniques is the cochlear nerve doesn't like any shearing forces, any pulling, right? You can move it up and down. You know, they're elongated depending on the size of the schwannoma. You can move them up and down. Like when you do, for example, petroclival and you have to go in front of the cochlear nerve, you move them up, you move them down, depending in which window you work, and it's totally fine. But the pulling, the shearing forces, that is what the nerve doesn't like at all.
Cochlear nerve is very strange. Because, you know, the most common complication of the microvascular decompression for trigeminal neuralgia is hearing loss. Maybe you just look the nerve, he's paralyzed. There is some trick to preserve it. This is, we need to know, need to understand. I don't know. I'm still seeking for it. I lost my hair, but I'm still waiting for it to find.
Can I have a question to Professor Ichimasu?
Yes,
Yes.
yes. Please go
Yeah.
on.
First of all, thank you very much for your nice presentation and this study on progressive hearing loss after surgery, after 3 or 4 years and progressing up to 7, 8, or 9 years. So my simple question is there any relation between the size of the tumor and progressive hearing loss after surgery? Did you do any kind of this study, correlation between size and also the correlation between the duration of hearing problem before the surgery and a progressive hearing loss after surgery? Do you have any idea about this?
In this phenomenon, post-operative hearing deterioration in very long-term period after surgery is there is no relationship between the size. Actually, if we want to preserve the hearing function, of course, the tumor size is very big big issue. Yeah, big. Yeah, very big. But yeah, if we preserve the hearing function once after surgery, it doesn't depend on the size, tumor size.
What about the symptom duration? Preoperative
Duration.
symptom duration, yes.
Actually, in this study, we didn't analyze, but
For example, if a patient has a long-standing symptom before surgery, maybe years and years, and then you do surgery. Another patient with a very short symptom and you do surgery. Maybe there can be some difference. Well,
yeah. In your opinion, yeah, there is some possibility to do something. The duration will affect the nerve findings. Yeah,
probably.
Like the tumor has long-term symptom. Sometimes much inflammation around the nerve. You know.
Exactly.
It's a very good point. Thank you.
Thank you.
Professor, yeah, I saw Professor 𝑬𝒑𝒂.
Yes.
Please.
Excellent, Professor Norio. I think that you have come to the cause that the cause lies in the inner ear. I think I'm correct if I could understand whatever you were told. What we have to see is that where the cause lies in the patients who lose the hearing after radiosurgery versus where the cause lies in the patients where we lose the hearing after 7 years even after surgery. Okay. Did you discuss with the neuro-otologist on the neuro-otology findings that what do they think about it? Because as you have told that the vascular could be a very remote possibility, because if this was to happen, then this should happen early. And 5 to 7 years happening later might be either there are some neural changes which have already gone into in the inner ear at that time of surgery because of the neurological involvement, and subsequently these have progressed further after 7 years and these people have lost the hearing. So what you have to see is that you have to speak to the neuro-otologist, compare the finding of the neuro-otology parameters in the patients who did not have deterioration versus the patients who had deterioration versus the patient who underwent radiosurgery also. They probably will be able to give us the answer that what is the cause of delayed hearing loss in these patients. As far as the technique is concerned, it's beautiful what you have told. And what it was discussed by the panelists also, that we can go up and down on the auditory nerve. We cannot go from lateral to medial on the auditory nerve, which is very well explained on the trigeminal neuralgia surgery. We have lost hearing in those patients also. But here the thing lies in inner ear. I think probably the neuro-otologist will be a great help to give us the answer. Whatever it is, it's the auditory physiology at the level of the inner ear which is causing problem. I think you will agree with me on
that. This study, thank you, question. This study has a member from neuro-otolaryngologist, and they analyze the various auditory tests, and we choose the ABR and DBOA. So yeah, because if we choose the ABR and DBOA, it's a very simple to understand. It's easy to understand, but I consulted about the mechanism of the deterioration, but they have no idea. Yeah, and firstly, when I see the data, hearing deterioration in the very long term follow-up, I thought opening internal auditory canal affect something for the hearing deterioration. But yeah, I have another study about the hearing function for the CP angle tumor besides vestibular schwannoma, and there is no differences opening internal auditory canal. So yeah, vestibular schwannoma, acoustic neuronoma is special. Yeah.
No, I think it has to be a very long study conducted amongst your neuroautological parameters prior to surgery, neuroautological serial parameters which had been going on till 7 years or later in the group who has got the deterioration in the hearing versus the group who continued to be the no deterioration in the hearing. I think that there is some problem going on at the level of the inner ear which is causing problem, as you have already defined this. It doesn't relate to the technique what you have done. I think again you can go to the neuroautologist, they should be able to give you the answer.
Okay, thank you very much.
Right.
Yeah. Professor Vodzik, yeah, please.
Okay. Professor Ioshimasa, thank you very much for great presentation. Very discussable, a lot of interesting data, and also it was an issue for me that post-op hearing deterioration is absolutely comparable with the deterioration after radiosurgery. So thank you for this information. It's the first I met it for the first time, and I will rely on it in my practice in the future. Unfortunately, all the questions I prepared were asked by Professor Rosner and Professor Borba. So anyway, I have my question. Do you consider the tumor size when you analyze your material? Did you include in your analysis the absence or presence of tinnitus in patients preoperatively, and did you rely on the level of hearing decrease before surgery, so minimal percentage before surgery? So what I lead you to the idea, what do you think? What is the reason of hearing deterioration? Our surgical procedure or pre-existing status of the cochlear nerve? What do you think? What is? How could you explain it?
Thank you. Thank you. Thank you.
I understand.
It's very tricky to explain that, but yeah, intraoperatively, we don't use spartel to preserve the cochlear nerve, and yeah, we try to preserve the membrane around the cochlear nerve, of course, but it's yeah, yeah, the mechanism is still unclear. Yeah.
Okay, thank you. Let us work behind. And I want to extend my comment a little bit behind the problem of EU exposed. I wanted to talk about the hearing loss on the one side, which is functional. So of course it's mainly about the patients with NF2. The preserving of hearing on the only one eye where the hearing is preserved. But when we discuss this problem, this problem gets not only medical, it's social, it's legal, and so on. So what is your strategy for patients with the only unilateral hearing preserved on the side of tumor? when you have a patient. Sometimes these are the patients with NF2, but also we have a patient without NF2, but only with hearing on the side of tumor. What is your strategy? Do you wait until the hearing will deteriorate, or are you more active? And how radical are you during surgery? How do you rely on monitoring, especially in cases with a big tumor, more than 3 centimeters?
Yeah, it's a very difficult question as well. And yeah, of course, for the patient of NF2, they have other surgical indication, you know. So yeah, so if the patient has a symptom like suddenly hearing loss or something, it means tumor affects much to the hearing function. The hearing function is very threatening, it means. So we have to perform the operation.
And be active.
Yeah, but we prefer to wait. Yeah, because yeah, that operation will be very stressed. Yeah, of course.
I agree. Okay.
Yeah, it's a very difficult problem.
Thank you. Thank you. Thank you.
Thank you. Professor Prichard, you have any
hello. Thank you very much, Professor Ichimasu. Nice presentation and good achievement. Thank you very much. And I would like to say that Professor Ichimasu is too young and but good experience. Thank you very much. And sometimes it's complicated, and we must support our young neurosurgeons. Thank you very much. Thank you.
Thank you.
Arigato.
It was first time to attend this meeting, and I have never have this this kind of presentation. I mean, this presentation is very long. Yeah.
Yes, it's brilliant. Thank you very much.
Yeah. Thank you.
Arigato gozaimasu.
Thank you so much. So maybe without further delay, we move to our last session. So I invite Professor Luis Barber to chair our last session and introduce Professor Praveen for the last webinar. Please unmute yourself, Professor Barber. Yeah, please. Yes.
Yeah. Good morning. When I saw the title of this presentation, I think, what this guy is talking about? And I'm here waiting to watch your presentation, intraoperative intermittent clamping of the sternal carotid artery for surgical removal of huge meningioma. Professor Praveen, a very well-known neurosurgeon from India, it's a pleasure to have you here. And please, go ahead. I'm here to listen to you.
Well, thank you very much. And is my slide visible?
Yes.
Am I audible?
Yes.
Okay, thank you very much. Well, I am Praveen Shrestha from Nepal. Professor,
Nepal. Sorry.
Yeah, and before I start, really, I would like to express my sincere thanks to Professor 𝒂𝒂𝒏 for giving me this wonderful opportunity, and also many thanks to Dr. Bunseng Liu for coordinating this webinar today, and also many greetings to all the chairs, speakers, moderators, and all the participants of this webinar today. Well, as Professor Barba said, well, what I'm going to talking about, well, I also don't know exactly what I'm going to talk about today. But anyway, this presentation is dedicated to all the ancestors and seniors of neurosurgery of the world. And also this dedication goes to the young neurosurgeons of the world. The young neurosurgeons are not only the young neurosurgeons, but they are also young scientists. And also they are the future leaders of neurosurgery of the world. Well, my presentation will contain basically two parts. The first part will be very briefly about global neurosurgery and neurosurgery in the world, because this webinar is the webinar for the young neurosurgeons of the world. So I just would like to briefly give some hints about how the neurosurgery developed in this world, which will contain briefly about history and global scenario of the neurosurgery in the world, and also a little bit about neurosurgery in my own country, Nepal. And it will be followed by the second part, which is intraoperative intermittent clamping of external artery for surgical removal of the meningioma. Well, to start with, whenever we talk about global neurosurgery, definitely the first thing that comes in our mind is Harvey-Cushing. But what I would like to, stress here is that before Harvey-Cushing came into existence, a lot of things happened in the field of neurosurgery before actually Harvey-Cushing started doing in the field of neurosurgery. So when we go back to the history of ancient medicine, this ancient medical practice developed from Greece, as you all know, more than 300 years ago, 3,000 years ago. But before it started in Greece, there were a lot of medical practice going on around the world more than 5,000 years ago. As you can see, Egyptian philosophy, Hindu philosophy about medical treatment. But this medical practice started some more scientifically from Greece more than 3,000 years ago. And when we talk about ancient neurosurgery, it seems it developed from Rome more than 2,000 years ago. Well, regarding the ancient neurosurgery, concept of neurosurgery, it started more than 2,000 years ago when Celsus, Roman philosopher, this person, he was not a physician that time, he was simply a philosopher, but he wrote the first medical textbook in the world, that time De Medicina, and in that textbook, it seems he had mentioned about brain swelling, concept of brain swelling. And in that textbook, he also mentioned that for the depressed fracture, the bone has to be removed. That means the concept of craniotomy is also mentioned in that textbook of medicine more than 2,000 years ago. Then came Galen more than 1,800 years ago, who was the Greek physician, and he developed the concept of brain and nerves and many other structures within the brain. And he also told that if there is a depressed fracture, probably it doesn't need to be removed. Only simple elevation of the bone will be good enough to treat the depressed fracture. And also, of course, he was well known for the pain of Galen. And then came more than 1,000 years ago, Al-Jarawi. Al-Jarawi was the neurosurgeon from Syria, later moved to Europe and many other places. Probably he is the first documented neurosurgical practitioner, because he used to treat surgically many patients with head injuries and skull fractures and spinal injury. So probably he was the first documented neurosurgical practitioner. Well, we are the medical doctors, we are neurosurgeons, so we always talk about who is the first surgeon, who is the first neurosurgeon, who is the first physician, like that. But we also sometimes need to talk about the first patient. So it seems this person, he is the King Henry II, King of France. Probably he was the first documented neurosurgical patient more than 750 years ago. He had sustained severe head injury because of the physical assault, and the neurosurgeon that time treated him, and fortunately he survived. So probably he was the first documented neurosurgical patient. Then came the era of the modern neurosurgery more than 175 years ago, when Paul Broca came into existence more than 175 years ago. He was a French physician, and he studied the anatomy of the brain thoroughly. And after understanding the anatomy of the brain, the whole scenario of neurosurgery changed. So the credit goes to Broca, who came more than 175 years ago. Then came many scientists, many surgeons who really significantly contributed to the development of neurosurgery. One of them was William Maswin, who is also regarded as father of neurosurgery by many of the people working in this field. He did the first successful brain tumor surgery in 1879. It was left frontal meningioma. Then came Peter Hasley, did many other surgeries, and he is also regarded as the world's one of the first neurosurgeons and one of the pioneers of neurosurgery. Did the removal of the first spinal tumor for the first time in 1897. Then, of course, finally came 125 years ago, Harvey Cushing. Definitely, he changed the whole scenario of neurosurgery, did thousands of neurosurgical procedures successfully, and of course, he is known as father of modern neurosurgery. Then came Walter Dandy, one of the pioneers of modern neurosurgery, did the first aneurysm clipping in 1937. And then finally, the Ghazi Yasharjil, who is the living legend of neurosurgery, and he's still very actively, teaching neurosurgery even at this age, and he's also regarded as the father of microneurosurgery. Regarding global neurosurgery, there are many news, articles, papers, many information, many things that you can find in the internet. And when I went through all these, information about neurosurgery in the world, the few facts that I could draw, I could point out of these many information is that at present, according to WHO, there are almost 50,000 neurosurgeons worldwide, serving about 8 billion of the population. And according to the American College of Surgeons and the American Association of ANS, according to these institutions, the ideal number of neurosurgeons is 1 neurosurgeon for about 100,000 of population. But recently, US government changed this ideal number or ratio of neurosurgeons. They thought that there is more demand of neurosurgeons. So ideal neurosurgeon would be 1 for about 61,000 of the population. So at present, worldwide, in an average, there is 1 neurosurgeon for about 160,000 of population. The highest neurosurgeon population ratio is in Japan, as far as I know, as far as I could find in the literature. There is 1 neurosurgeon for almost 16,000 of the neurosurgeons. So this is the highest ratio of neurosurgeon population in the world. Similarly, the biggest neurosurgery community is in China, more than 11,000 of the neurosurgeon, where there is 1 neurosurgeon for about 127,000 of the population. Similarly, in South Korea, it seems they also have very good number of neurosurgeons, 1 for about 17,000 of population. In Australia, 1 for 50,000 of the population. In Canada, 1 for 52,000. In Russia, 1 for about 56,000. In US, 1 for 89,000 of the population. And in UK, there is a slightly less ratio. There is 1 neurosurgeon for about 165,000 of the population. Well, very less number of neurosurgeons are there in Africa. So probably the lowest ratio is in Congo, 1 neurosurgeon for about 18 million of the population. And in Ethiopia, 1 neurosurgeon for about 1.2 million of the population. Well, if we consider this is the ideal ratio of the neurosurgeon population ratio, 1 for about 100,000 population, then only 33 countries in the world have enough number of the neurosurgeons, 1 for about 100,000 of population. And more than 161 countries in the world, they still have very suboptimal number of the neurosurgeons, less than 1 for about 100,000 population. And 31 countries have even much less neurosurgeons, 1 neurosurgeon for 250,000 of the population. And it seems that 33 countries still do not have any single neurosurgeon in their country. This is the rough estimation of the distribution of neurosurgeons in different continents. This is not the exact data. I tried to collect some of the information and found that almost 40% of the neurosurgeons are located in the Asia, similar 28% in Europe and 10% in South America, 19% in North America. However, the neurosurgeon population ratio is best in North America, about 1 for 81,000 population. Similarly, the least number of neurosurgeons is in Africa, 1 neurosurgeon for about 1.2 million of the population. Regarding women neurosurgeons in the world, well, female neurosurgeons, women neurosurgeons have also significantly contributed to the development of neurosurgery in the world. There are some controversies regarding who is the first woman neurosurgeon in the world, but it hardly matters. I think what is more important is they have contributed significantly. May it be Diana Beck from UK, more than 80 years ago, or may it be Sofia Ionescu from Romania, or may it be Krishna Kanaka from India. They all have significantly contributed to the development of neurosurgery. And finally, Professor Yokada from Japan, who is still a living legend in the field of women neurosurgery, significantly contributing to the neurosurgical field for the last more than 45 years. Regarding the proportion of the women neurosurgeons, few countries have really big number of women neurosurgeons, like in Italy, 36% of them are the females. In El Salvador, 29%, Denmark, 26%, Uruguay, 25%, Finland, 25%, USA, 12%, and Japan, 6%. But few countries have really very few female women neurosurgeons, like in Kosovo, Cyprus. Probably they don't have a single women neurosurgeon yet. Even in South Korea, having such a huge number of neurosurgeons, women neurosurgeons are just 1.7%, Kazakhstan 2%, and India about 2.5%. Well, now talking very briefly about my country, it's a small country in South Asia between two giants, China and India, with about 30 million of the population. This is the country of Himalaya and Mount Everest and all the high mountains, and also this is the place of Lumbini, which is the birthplace of Lord Buddha. Well, we have about 114 neurosurgeons at the moment, and with 8 females and 106 male neurosurgeons. So proportion in our country, the proportion of women neurosurgeons is about 7%, whereas in an average, in the world, the proportion of women neurosurgeons is about 19%. Well, in my place, Kathmandu city is the capital city, so more than half of our neurosurgeons are located in the capital city, and less than half of them are in other parts of the country. Somehow our neurosurgeons are more fascinated towards the private practice. More than half of them are involved in private practice, and probably our government service is not that good. So only 17% of are involved in the government service. This is the development of neurosurgical manpower in my place. The first qualified neurosurgeon came only in 1988. And for these 2 decades was very poor in the sense of development of manpower. There are only about 50 neurosurgeons in these 2 decades of time, including myself. Then after that, there was sudden and rapid rise in the number of neurosurgeons, and in about 1.5 decade, almost 100 neurosurgeons came. So this is the production of neurosurgeon every year. We have almost 10 residents every year, and in addition, few of the neurosurgeons are also trained abroad, like in the US, like in Japan and India, and they come back to Nepal and they are working as a neurosurgeon. So almost every year we are having more than 10 neurosurgeons, new neurosurgeons. This is the distribution of neurosurgical service in the country. There are 7 provinces in my country, and this is the province number 6. This is the remotest area in my country. So at present, even in such a remote area, we have neurosurgical manpower. And recently, our neurosurgical service has become more easily and widely accessible throughout the country. Even in the remote area, we have plenty of CT scanners and 3 Tesla MRI and few neurosurgeons working there. So recently, the neurosurgical service in our place has become much better. This is the again ratio of neurosurgeon and population. Well, in Nepal, as you can see, there is 1 neurosurgeon for about 263,000 of the population. When compared with other neighborhood countries in Afghanistan, this data may be slightly wrong. Again, it is approximate data. It's very difficult to find out the exact data. In Afghanistan, the ratio seems to be 1 for 322,000 population. In Bangladesh, relatively there is small number of neurosurgeons. 1 neurosurgeon for more than 1 million of the population. Similarly, in Bhutan, they have only 2 neurosurgeons so far, and neurosurgery is not that well developed yet. 1 for 390,000 population. In India, again, huge number of neurosurgeons, the ratio being 1 for 284,000 population. In Maldives, recently they have been doing quite good in the field of neurosurgery. They have 5 neurosurgeons now, but only 2 of them are local, and the rest 3 are foreigners. Out of those rest 3 foreigners, 2 are from Nepal. And they have the ratio, very good ratio, 1 for about 100,000 population. Similarly, in Pakistan, 1 for almost 1.5 million of population. In Sri Lanka, they still seem to have quite a small number of neurosurgeons, 1 for 934,000 population. In China, 1 for 127,000 population. And in an average in the world, 1 for 160,000 population. We have Neurosurgical Society of Nepal called Nepali Society of Neurosurgeons. There are two chapters, neurospinal chapter and neurovascular chapter. So far, subspecialized is getting much better these days. We have dedicated and highly qualified skilled spine neurosurgeons. We have endovascular neurosurgeons. We have functional neurosurgeons. And we have our own official journal, Nepal Journal of Neuroscience, which is in depth in many research engines. Well, now coming to the second part of my presentation, it is meningioma surgery. Briefly talking about meningioma, the term was coined by Cushing in 1922. As it is obvious, everybody knows it is one of the most common benign intracranial tumors, most common intracranial tumors. It is more common in the middle-aged females. It is one of the highly vascular tumor. And according to WHO, grade 2, grade 1 benign meningiomas occupy about slightly less than 90% of the cases. Grade 2 is atypical meningioma, or slightly less than 10% of the total cases. And malignant meningioma, grade 3, is less than 5%. That includes papillary and aplastic and diabetic meningiomas. Well, these are the common types of meningiomas. Olfactory group meningioma, convexity, parasocial and sphenridge meningiomas are the common ones. Less common ones are posterior meningioma, occupying about 10% of total cases, spinal meningioma, about 10% of total cases, and intraventricular meningioma, about 3% of the total cases of meningioma. Well, meningioma is a very vascular tumor, so sometimes the bleeding can be a really big problem, and bleeding can be as much as 2,000 ml of blood loss during this meningioma surgery. Most of the blood supply is through the meningeal branches of the external carotid artery. A small proportion of the blood supply also comes from branches of the internal carotid artery, mainly through the choroidal arteries. Bile supply also comes from the branches of the internal carotid artery, and small proportion of blood supply can be from the vertebral artery, especially in those mainly in the pelvis meningiomas. Well, these are the different meningiomas according to anatomical location, and this is the arterial supply. As you can see, in most of the cases, the branches of external carotid artery are the main feeders of meningioma in different locations. So high vascularity is the main problem of the meningiomas, and it is often reflected by the peritumoral edema. If there is significant edema, that suggests the high vascularity of the tumor. And retrospectively, if we analyze, then these are the markers which are found in the highly vascular meningiomas like VEGF, MMP2, MMP9, TIMP. And this high vascularity is positively correlated with the tumor growth and recurrence. So that if the tumor is highly vascular, it grows faster, and there is high chance of faster recurrence of the tumor if there is a residual. But this vascularity is not correlated with histological malignancy. This is what has been found so far by different studies. So vascularity is the main threat and challenge for the successful surgery of meningioma, and the pre or intraoperative devascularization of the tumor is the main key for the successful surgery. Well, now here comes the importance of preoperative embolization. It has already been established procedure to embolize the tumor, and it helps to devascularize the meningioma before surgery. Basically, during embolization, they embolize or block the dural branches of external carotid arteries. But whenever there is a large meningiomas, because of the lot of collateral vessels, sometimes the embolization becomes more difficult and more challenging. And embolization of the internal carotid branches, embolization of the vertebral branches can be risky, as they can produce ischemic complications. And moreover, in larger tumors, if some studies have shown that there is no significant distribution in the blood loss during surgery, whether they are embolized or not embolized before surgery. And moreover, embolization, endovascular embolization is a high-tech procedure. It demands a lot of things. Mainly these 4 M's, they are manpower, highly trained endovascular surgeons, materials, a lot of materials they need, and of course time, it takes time, it consumes time, and finally money. Of course, it is quite an expensive procedure, especially in our place. So now here in this context comes the ligation of the external carotid artery, where external carotid artery ligation is a very old technique. It is, of course, not new one, but these days it is less commonly used. Especially these are still helpful in the case of mass lesions in paranasal ear sinuses, nasal cavities, oral cavities, and extracranial masses which have extended into the intracranial space. In such situations, still this external carotid artery ligation is practiced. And moreover, temporary ligation, not the permanent ligation, temporary ligation or clamping of the external carotid is very safe, it is stand, it is effective, and it doesn't cost at all anything. So here comes the usefulness of the external carotid artery, especially useful and can be alternative to embolization in certain situations. So temporary ligation of the external carotid artery in case of meningeal surgery can be useful whenever the preoperative embolization is not possible due to any reason. So it causes temporary devascularization of the tumor. There is significant reduction of the blood supply to the meningioma if we clamp the external carotid artery temporarily during the surgery. It is especially helpful for any kind of the meningiomas. There is marked reduction in the blood loss during the surgery. The surgery becomes fast and easy, and there is very minimal postoperative complications. So it is very useful, especially in case of emergency situation where the preoperative embolization of the tumor could not be done. Here are a few illustrations where this is a young patient came in the emergency with severe headache, vomiting, and finally loss of consciousness. When we did his CT scan and MRI, this was the finding which we found: huge mass with significant edema, brain edema with significant mass effect, and the patient came unconscious in the emergency room. So this was the mass lesion again shown in the MRI. And in such case, we don't have, of course, time to embolize the patient. So what we do in such cases, we expose the carotid. This is a common carotid. This is an external and internal carotid. In fact, in this case, we did a thorough, dissection of the whole structure. In fact, this is we do not need to expose the carotid so extensively in routine cases. In this case, it was done thorough dissection just to demonstrate to the young neurosurgeons and residents. In fact, this much of extensive carotid exposure is not required. And dissection is very, very easy. As we are neurosurgeons, we play around these structures quite commonly during any neurosurgical procedures. And it's very easy to find out external and internal carotid artery because of the branch. This is the superior thyroid branch. This is the first branch of external carotid artery. So when we see this branch, then we can definitely say, yes, this is the external carotid artery and this is the internal one. Sometimes it may be difficult to find the branch. In such cases, we can find external carotid artery because it lies more anteriorly than the internal carotid artery. So dissection is not at all a problem. During surgery, we clamp the external carotid artery temporarily. We can release again and can clamp again. And this is the postoperative image complete resection without any much difficulty. This is, of course, even young neurosurgeons can do this surgery very easily. But the thing is how easily we do the surgery with minimal blood loss and with minimal possible postoperative complications. So this is another young patient who came to our outpatient clinic with headache, but more than headache, he was having rapidly deteriorating bilateral vision. When we did the CT scan and MRI, this was the large meningioma again with significant mass effect because of the tumor and because of the cerebral edema. Again, in such cases, we immediately planned surgery next day. In such cases, not only the tumor bleeds a lot, but bleeding starts right from the scalp incision. Bleeding starts right from the craniotomy. The incision and craniotomy itself becomes so difficult because of the significant blood loss during surgery. And this is what usually we expose. We don't need to expose extensively all these things. Just expose common carotid artery. It's bifurcation. Just try to look the branch, superior thyroid artery, and just little bit dissection around the external carotid artery, just to create the space for a clamp. And after clamping, the surgical field becomes so clean, so dry, surgery becomes so easy, and we can take out the tumor within very short span of time, and thus very minimal blood loss and very minimal post-operative complication. And this is the patient after 2 days, and this is the incision mark exposing the carotid artery. Similar, this is another lady, again came in the emergency with history of headache and loss of consciousness. This was the finding in the CT scan. Again, same technique, exposure of the external carotid artery. clamping it intermittently, opening it sometimes to see how extensive is the bleeding. If there is again severe bleeding, then we can again clamp this external carotid artery, again dissection around the tumor and remove the tumor, and finally open the external carotid artery before we close. So this is the lady again with this incision in the neck for the exposure of the carotid. This is another lady with again meningioma, but in this case, as you can see, the suprachiasmatic artery has been invaded by the tumor. In such cases, we plan to leave a small piece of the tumor around here without not to create the complications around the suprachiasmatic sinus. So again, we did the same thing, plan for the carotid exposure, at the same time plan for the craniotomy. And this is the postoperative image. This lady was operated around 5 or 6 years back. Every time, 1 or 2 times in a year, she comes in for a follow-up. We do MRI every time. There was small residual tumor. There was no regrowth of the tumor at all. Rather, the tumor has regressed. But in this case, as you can see, in this case, we have permanently ligated this external carotid artery because there was small residual tumor that we had already planned before the surgery. And after this ligation, it is already almost 7 years, and there's no regrowth. Rather, the residual tumor has regressed in the site. So there are a lot of advantages of external carotid artery clamping. It reduces the intraoperative blood loss. All the feeders are almost clamped, blocked during the surgery, and it is useful for any kind of the meningiomas, and there is very easy access for releasing. So if you think there is some vascular compromise, then you can release the clamp, but it is usually it doesn't cause any vascular compromise during the surgery because of the clamping of the external carotid artery, and it is quite safe and cost effective. Of course, there can be some disadvantage of this procedure. It is said that there is a risk of scalp necrosis because of the permanent clamping of the external carotid artery, and that can lead to the infection. There is also possibility of retrograde thrombus formation if we play around a lot of playing around the internal carotid artery. It can cause sometimes thromboembolic complications through the internal carotid artery. There can be sometimes difficulty in carotid dissection, and of course it takes time. These are the disadvantages, but time is not a big issue. It takes hardly 30 minutes of our time while dissecting the carotid. So in conclusion, external carotid artery ligation is instant, it is cost effective and very helpful. It is very safe. Carotid exposure at times can be difficult, but we are neurosurgeons. We do carotid dissection quite often. Even like when we do surgery at the level of the high cervical spine, we come and we work around that anatomical location. So carotid exposure is not at all a difficult procedure for us. But of course, we need to have a good skill of general neurosurgery so that there won't be any difficulty in carotid exposure. It is definitely better to have thorough carotid and cerebral angiography before we plan to ligate the external carotid artery. And we do this quite often before surgery if we have enough time. And of course, we better to have the facility of endovascular embolization of this kind of huge meningiomas to prevent the blood loss. But if this endovascular embolization is not available, then definitely external carotid artery ligation, temporary ligation can be the better option. Well, this is what I had to say in this presentation, and thank you very much once again for your patience and for giving me this opportunity. Thank you.
Excellent, excellent, Praveen. 2 points are very important. I think. The first part of the presentation, this data is very, very important to us, very, very important to understand what's happening today in the world. And maybe the focus of our federation is completely wrong. We are not focused in the real issue. That is the real mission of the federation. Instead of spend a lot of money with another issue, and fighting for nothing. We're not doing our job. We need to change the route, we need to change the way. We hope in the next years, you can come back to do what you really need to the neurosurgeon in the world. The second part of the presentation is very interesting. I never saw this, but it's a good idea. You see, very good idea. I don't use preoperative embolization for meningioma, except in case this is a very large convexity meningioma, that in the first borehole is bleed like crazy. In this situation, you can use the preoperative embolization. But the complication, especially to the skin, in the preoperative embolization, is not so rare. See, sometimes you see this, always you see something different. Maybe this idea, your idea, that a temporary closure of the sternocleidomastoid artery could be a good idea. Because you do a temporary closure, you do the job, and you release.
Yes.
Yeah. Maybe it's a good idea but for select case. Some case that you show the vascularization is coming from the middle meningeal artery or from the dura by itself. That one was in the base, you can go under the tumor and take. Maybe you don't need to do the embolization.
Exactly, I agree. Yes.
But it's a good option, especially for low and mid-class country, that not so expensive, you can do this. I will keep in mind. Now I learn. I always learn in these webinars. You know? It's very. I just talk with Raja. Sometimes, what the guy is talking about? Well, very nice idea. Congratulations.
Thank you.
Professor ৱozniak. Please,
Yes,
Professor ৱozniak,
yes, I'm here,
Florian,
Professor
and
Borba.
all the people.
Thank you very much. So thank you very much, the Dr. Shrestha. Thank you very much for the first part, very informative and really very interesting, and in some point even a little bit disappointing me, because the sad statistic for Africa and from some Asian countries. Recently at the 𝒂𝒂𝒂 Congress, we discussed this topic also, the World Neurosurgery sections. We discussed this. And what is most disappointing, that the practice of training of neurosurgeons from developing country is not so effective, because the majority of them are trying to stay at the countries where they were trained. So it was proven that the most effective way to train neurosurgeons is their training in their hospitals by teams of experienced neurosurgeons who come there and train on site. And from this point is flowing my next comment about the second part of your report. So I understand that you was in condition when you had to perform the effective surgery with a minimal equipment. And really, it was actually a rational solution in that situation. Of course, for people who work in clinic and where they have endovascular embolization, where they equipped very well with the non-stick bipolar, different bipolar, ultrasound, and so on, and they can reperfuse the blood, the 1 liter blood. It's not a problem for them. Of course, they even do not think about it, but you thought about the patient, and you really proposed the rational solution in their spectacular case for that cases. So really, I congratulate you, and I wish you to have more equipment in your hospital, and to maybe in the future avoid this procedure, but still you in your hospital, on your place, you decide what to do, because the interest of patients is the paramount of all this process. So thank you very much, and my congratulations.
Thank you very much. Thank you.
Professor Rosa, any comments?
Yeah, he just said he needs to leave. He's
Okay.
on call. Just go.
Sure, sure.
And he was.
Professor Priset?
Thank you for the participation.
Yes, thank you very much.
Professor
Thank you very
Kovai.
much, Professor 𝒀𝑵𝑚. Thank you. And I would like to say thank you for two presentations. Yeah, at the same time, and I would like to also thank for Professor Praveen for hosting the last South Asian Neurosurgery Congress, and it was with good and high achievement and supporting especially low and middle income countries. Thank you very much. And I would like to say on behalf of low and middle income countries, draw your attention for supporting these countries by trainings like scholarship, fellowship, and short-term trainings, and also for equipment and instrument as well, because our people are very poor, and you know, and we are in very difficult situation, and as you know, that's very different between high income countries and low and middle income countries, and would like to ask, draw your attention. Thank you very much. And I would like to say for your second part of presentation, thank you and congratulations for your achievement. And we are proud of you. We are part of South Asian Neurosurgery countries, and we are proud of you and your achievement. And also, I would like to draw Professor Yaku attention for this issue, and for more supporting this part of world. Thank you very much.
Thank you very much.
I was just talking with Raja now by WhatsApp. These webinars are very nice. You see so nice ideas in the world is completely different. It's completely different. In every place, there is very good people with very good mind. You just need opportunity and give something to develop. Yeah. We need to do that. We need to do that. We need to do that. Thank you very much for the opportunity to be here. I really enjoy here to be here to you.
Thank you so much, Professor Baba. So, if there's no more further questions, shall I invite Professor Kato to say some final few words before we end this?
Thank you so much. So, at the beginning is thank you very much, 𝑬𝒙𝒑𝒆𝒂𝒌𝒆𝒓 Sensei. So now you are in France already. Yes.
Yes.
Already you are in France now.
Oh, actually not yet.
Not yet.
Yes.
Not yet.
Next
maybe
week.
soon. I think.
I
Yes.
will go.
Thank you very much for your, even at a very young age, that you presented it so nice. Maybe under the education with Dr. Kono Sensei. So maybe you should continue. You're a great mentor, and also maybe the further your research in France. Maybe in the next 2 years, fellowship. Or best.
It's gonna be 1 year. Yeah.
Only 1 year. Even though, thank you very much.
Yeah.
Also, okay, thanks. Also, James from US, he recommended by Baskaya. His presentation is the glioma. Glioma is one of the most difficult fields, but I think in the field is minimally invasive. Some treatments, even though such a very difficult field, I think. So the more the service for the patient is in the future. And Praveen, thank you very much. So that you are one of the leader of the Asia, especially South Asia. already you promote your country and also the Nepal itself. I congratulate. Maybe even though the YNS, we can accept not only our university, but also many of the world, I think, open to the country that anytime you send your fellow to a place. I think once the setup has finished, maybe I think YNS can start anytime to the higher, I think, techniques for the patient. And thank you very much, Volver. You wanted to say, because you focus on the WFNS now, I think. So WFNS has not changed in the last 20, 30 years. I always think about the same things as you mentioned. So please, you can change the WFNS itself, okay?
But I need you, and all of you.
Okay, we're ready.
Yeah. Yes, it's a time to change, I think, but it's quite difficult. I wished the last 20 years, but it has never changed. And also, I thank you very much, Dr. Florian, that even you had good time. You gave us so many nice comments. And please involve our educational activity more in the future, please. And also, as discussed, Dr. Alexander, you sent me the recent two young, very promising doctors. So we worked together. So then we understood the situation of the Ukraine the hospital, because their hospital is located very west side.
Yes.
Yes. So maybe not the east side. So more involved with the rehabilitation, but he very focused on the surgery. They watch the surgery very seriously. They learned a lot from us, I think. I hope. So I think you can send a couple of the doctors to a place.
Yes, I'm preparing. I even have already candidates for this. I will send the data and according the functional neurosurgery.
Yes.
So maybe let us postpone that visit. It's not enough time from the 1st of November to start. Maybe after New Year.
Okay.
After New Year. Okay.
After New Year. Okay.
After New Year.
So in Japan, we have so many chance to see the stereotactic or functional neurological activities. So anytime, please.
Great. I'm working on that.
Okay, thanks. And also, thank you very much always. So I really want to support your country, but just you can send us your young doctors. Then we can start our collaboration. It's quite difficult to get a visa to Afghanistan. And also it's very difficult to enter your country. So please just send us their colleagues. Anyway, thank you very much for the nice, it's a bit long. I hope that the young doctors can understand very nice 3 lectures, and you can learn a lot from them. So maybe till next time, I think. Dr. Ben?
Yes. So thank you so much for joining us today. It's a bye-bye to all of us. And today we are really having a very wonderful and educational lectures, and also very fruitful discussion. We all learn a lot. And without further delay, then I would like to end this webinar. And on behalf of the Educational Committee of ACNS, I would like to thank you all for joining these webinars this evening. And so I hope we'll see you all next time. So goodbye to all.
Bye-bye.
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 Bye-bye. Bye-bye.
Bye-bye. Thank you.
Bye.
Thank you. Bye.
Ciao.
Bye-bye.
Ciao.
Thank you so much.